You guys hear me? Anybody hear me?
Hello, dear doctor.
Okay.
Yeah, your voice is
Okay, well, welcome to second session. And today we'll concentrate on monitoring the ventilation. And we'll speak a little bit about ventilation, but we will take ventilation in a separate session. But today is how to monitor ventilation. So do you have any question about the previous session? So I don't know how to remove this line. I did something and this line appeared. Don't know how to remove it. Not sure what happened. Anyhow, so any question about the previous session? Anybody have any question, comment on the previous session? No? Okay. So today we'll take how to monitor a baby who's ventilated. Now there is an abbreviation that we should use, okay, in ventilation. And when you start to fill up the sheet for ventilation, you need to know that. Now in ventilation, we have variables, متغيرات, variables. The first variable is called controlled variable. And the controlled variable give us two types of ventilation, either volume control or pressure control. The volume control usually used by anesthesia and during surgery. The pressure control, we use it mostly in intensive care. Sometimes we use volume, but rare. Okay, that's called control variables. There are other variables called phase variable. The phase variable are two types, dependent and independent. I don't want to go to details, but phase variables, together with the type of a breath, give us something called mode. So the mode are controlled by phase variables and type of breath. Now, when we ventilate a baby or a child, we have three types of breath. Remember them always. Spontaneous, that is generated by the child and terminated by the child, called spontaneous breath. Second, called assisted breath, started by the baby and completed by the machine. And the third breath, called mandatory, that is given by the machine. So one done by the baby, one done by the machine, and one started by the baby and completed by the machine. So assisted, mandatory, and spontaneous. So the type of breath, these are three, and the phase variables give us the mode, is how to give a breath. So remember, control give us type of breath, whether it's volume control or pressure control. Phase variable and type breath give us the mode. And the mode is controlled by phase variable and type of breath. And the mode is the way we ventilate the baby. And we'll have different modes and we will learn them with time. So there are some modes called assisted control. Assisted control. Okay? Assisted mean assisted breath. Control mean the mandatory breath. So in this mode, we only give control and assisted, called AC. So if the baby is on assisted control, the abbreviation is AC. There are other modes called PSV, pressure support ventilation. We'll learn it with time. There are PR PVC, or pressure regulated volume control. There is something called nasal CPAP. CPAP is continuous positive pressure, and we will learn with time. There are other modes of ventilation. The mode of ventilation is either conventional. Conventional mean the rate that we give it is the same that a human being can tolerate. So the rate of a human being is from when you're very young, or up to 60, and when you are like adolescent, it's reached down to 12. So if we give 12 to 60, so probably you are conventional mechanical ventilation. But there are, sometimes we give very, very high rate in very sick baby, 600, 1000. Okay, this is called high frequency, and the abbreviation is HFV. We also give nasal prong and nasal cannula, and later on I will explain you what the difference. There are other modes of ventilation called SIPBV, synchronized intermittent positive pressure ventilation. And there is CMV, controlled mandatory ventilation. We will learn with time what are these type of ventilation. There is another mode called SIMV, synchronized intermittent mandatory ventilation. Remember we said volume control and pressure control, so PC and VC. There is PIP, one of the variable is positive inspiratory pressure, which is the pressure giving the baby during inhalation, خلال الشهيق. LMP is liter per minute. This is one of the abbreviations that used in ventilation. INO is inhaled nitric oxide, is a gas that we give to treat pulmonary hypertension. TCPO2 is transcutaneous oxygen, and then we'll learn later what is TCPO2. TCPCO2 is the same of TCPO2, but it's for the carbon dioxide. PEEP is the peak and expiratory pressure, is the pressure that we give to the baby during exhalation. Mean airway pressure, we'll learn. Inspiratory time is the duration of PIP. UAC is umbilical arterial catheter. UVC is umbilical venous catheter. CBG is capillary blood gas. ABG is arterial blood gas, and VBG is venous blood gas. In the blood gas, we have to mention always pH, PCO2, PO2, and bicarb. Also, something called base excess or base deficit. If you write PE and then you write the number, you have to write the sign before, plus or minus. And minus is BD. So you can write base excess plus 2, base excess minus 2, or you write base deficit is 2. You also have to mention lactate. Any comment write about the abbreviation. These are just abbreviation. I'm not teaching you anything. But when we start to write the sheet, you always write in abbreviation because there is no space. Any question? Okay. Now, when we write, we follow the baby. The flow of work is usually depend on the shift. So if we do 12-hour shifts, we have to have 2 sheets, 1 sheet for every 12 hours. If we do 8-hour shift, we have to do 3 sheets. So we start with the sheet. We start by the date. So we write the date here. And then the timing. So this is 1 to 12. So if it's from morning, let's say start from 1 a.m. or depend on the shift, we can start from 8. So this is 1 a.m., 2 a.m., 3 a.m., 4 a.m., 5, and so on until 12 a.m. And then the second one will start another sheet. Then here we have to mention the mode. Is it AC? Is it PAC, assisted control? Is it PC, PSV, pressure support ventilation? Is it SIPBV, synchronized intermittent positive pressure ventilation? Is it, for example, SIMV? Is it CMV? Is it high frequency? And here we mention FiO2. FiO2 is the abbreviation of fraction of inspired oxygen, is the amount or the percentage of oxygen that we give. And we can write it in percent, 21%, 30%. Okay, we also write the ventilation rate. And the ventilation rate, we have beat per minute. So how many cycle per minute? One minute, please. Give me 1 minute. So we write also the ventilation rate. Each 1 hour, we write what is the ventilation rate. We write the PIP if we are ventilated the baby, which is usually measured by centimeter water, positive inspiratory pressure. We write the PEEP, and it's also measured in centimeter water. We write the MAP, it's also in centimeter water. And we write the inspiratory time. Is it 0.36, 0.37, 0.38, 0.4, and so on. We write the flow, which is liter per minute. And if we are on inhaled nitric oxide, is part per million, part per million. Okay, so this is the first part, which is the oxygen and the ventilation parameter. Okay, and then we write the blood gas. So when we write the blood gas, we write the saturation. Remember, we wrote previously in the previous slide, we wrote the FiO2, how much we are giving, and now we are measuring, right, how much we are measuring. We can also, if we already have, we can write the TCPO2 and TCPCO2, which is usually measured in millimeter mercury. We also can write the end tidal CO2 is the CO2 that measured in the machine, while the TCPO2 and TCPCO2 is measured from skin. We can also write the oxygen index, and I will teach you later what's oxygen index. And then we write the blood gas. So first we write from where we get the blood gas. Is it from UAC? Is it capillary? Is it radial arterial artery? Well, where is it taking? And then we write the pH, the PCO2, the PO2, and the bicarb usually are of two types. The first bicarb called standard bicarb, which is the measure in the blood gas, and the actual bicarb, which is measured from the serum and usually measured with the electrolyte. So remember that the bicarb that is measured by blood gas is calculated, is not real. While the one measured in platelet, it's measured from the CO2 and the pH, and you give us the PHCO3. While the plasma, it's actually measured chemically. We can write the base excess. In base excess, you have to write sign, plus or minus. And base deficit, you don't need to write the sign. You give the lactate in the blood gas, and if there is hemoglobin in the blood gas, if there is potassium and sodium, and if there is chloride and calcium. So these are how we write the blood gas in the sheet. We also have to write the clinical finding. So we write whether X-ray is done or not. Is it lung ultrasound done or not? And if the child has increased work of breathing. And then we will learn later how we write the increased work of breathing. We can also write our initials. Okay? We also write about the airways, whether we did suction for this baby and how many times we did suction. Also, we write what is the size of the ETT, endotracheal tube. We also put where is the tip of the endotracheal tube, because this is usually changed when we change the head to the right or to the left or mid, or we put the baby prone position. The tip change, and once we change, and and it depends how you measure it, by ultrasound or by X-ray. You have to write the tip, and you also have to write when the ETT is changed. And here I finished this chart flow, and I'm going to show you right now how's actually the chart appear. So you give me 1 minute, I will show you the actual chart.
Doctor, the chart was good, but can you explain more about the standard bicarb versus the plasma bicarb? I didn't get it.
Yeah, okay, I will. But let me show you first the chart, the actual chart, and then we can discuss about that.
Okay.
So this is the actual chart that you will use. So you have the name of the chart, and then you have the abbreviation in front of you, and the parameter of the blood gas, and then you start, you put the date, and then the time. Now here is 12-hour timing, and the shift, of course, this can be changed. The shift starts from 12 to 12, but you can change from 8 to 8, or 6 to 8, or we can change it to 8-hour shift. I'm not sure how that goes. And then you start to fill. So the first part is the ventilation and the oxygenation, and you can see how we fill it. And then we put the blood gas, and then we put the clinical, and then we put the airways. Okay? So you asked me about the blood gas. Now we will have a session about interpretation of blood gas. However, you asked, and this today is only showing you how to monitor a baby on a ventilation, how to document that. So the bicarb, or all the blood gas, are actually all calculated. The base excess, the base deficit. Okay, there is three are measured: pH, PCO2, and PO2. Any other things in the blood gas are calculated. It's not measured. So the blood gas, we measure only 3 parameters: pH, PCO2, PO2. Everything else is calculated from these 3. So standard bicarb, calculated bicarb, is from blood gas, while plasma bicarb are actually measured chemically by a machine, and usually comes with the electrolyte. Okay, so the standard or calculated bicarb reflecting the CO2 and the pH. So it's not actually reflecting the real bicarb. Okay, and the difference, if we measure both, what's real bicarb is the plasma. The difference is the compensation, because remember, when bicarb is high, we have metabolic alkalosis, then the CO2 will accumulate. Okay, so once the CO2 accumulate, you get higher, you get lower, sorry, because once CO2 high, the pH will go down, you get lower bicarb than the actual bicarb. So remember that the bicarb in the blood gas is calculated, while the bicarb that is in the serum with the electrolyte are actually measured. Okay, so I'm gonna give you on the WhatsApp a copy of this sheet. And I want questions. If you guys have any questions, just feel free to ask anything you want. And you can ask in Arabic or Kurdish, whatever you prefer language. It's not a must to be in English. So if you feel that you can express yourself better in Arabic, you can ask
calculated parameter.
Wait, sorry, again?
Just about calculated parameter.
Calculated
do we
parameter.
do that, or calculated, or the devices do that? For example,
device.
image analyzer do that, or We should.
No,
We
the
should do that.
device. No, the device will calculate. You won't calculate anything, all by device.
Good.
But what I'm trying to tell you that only the blood gas machine only measure 3 parameters: the pH, the PCO2, and the PO2. Everything else is calculated by the machine. You don't calculate. You understand? You don't calculate anything. Okay?
Great, dear doctor.
Any more questions? So if you don't ask question, I will ask. So it's your preference. Just ask me anything. 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 No questions? Can I ask? Do you guys want me to ask so you can remember everything and rehearse again? Talk to me. Do you want me to ask you a question or end the session? So we can learn more. Okay, so let me share with you. Anybody can tell me what is mode? Anybody knows what is mode?
For example, dear doctor, for example, AC, VC, and pressure control is like variables within the ventilators. It contain FI2, pressure control, PEEP,
Very
tidal
good.
volume.
Very good. Very good. So you mentioned the content, but you didn't define it. So the mode is the type of support we provide to the baby, is the type of support of respiratory or ventilatory support we provide the baby. The mode is the type of ventilatory support we provide the baby, and it depends on two. First, depend on the phase variable. Okay. Also, there are other type of variable. Phase variables mean when the phase of the breathing cycle change. So we have beginning of inspiration, and then we have inhalation, and then we have the end of inhalation, and then beginning of exhalation, and then the end of exhalation. These are time. So we have inhalation, we have exhalation, we have pause. Okay, when there is neither both, baby is not breathing. So these are called phase variable. There are variables that we set for the baby. We put it in the machine. This is called independent variables. The reason why called independent, because they are independent on the baby. Okay, so these are variables that we set, such as PIP, such as PEEP, such as inspiratory time, such as the rate. These are called independent variables. There are other variables called dependent variable. These are variable are interaction between the baby and the machine. So also called sometimes measured variable. So these are the variables that you see it on the monitor of the ventilator. These are called dependent variable because they are dependent on the interaction between the baby and the machine. So remember, we have independent variable, or the set the variable is the variable that is set by the clinician of the or the nurse. And so that's why called independent variable. So remember, we have phase variable, we have independent variable, we have dependent variable. And then we have three types of breath. We have assisted, that started by the baby and completed by the machine. And we have mandatory, that's only controlled by the machine. And we have assisted, so that's the breath that never assisted by the machine. Okay, sorry, spontaneous, that is never assisted by the machine. So we have three types of breath. We have phase variable, we have dependent variable, we have independent variable. Combining these is the type of the support that we give the baby when we combine it. Okay, and that's what we call it mode. And there are different types of mode, such as assisted control, such as pressure support ventilation, such as pressure regulated volume control, such as high frequency ventilation, such as controlled mandatory ventilation, such as synchronized intermittent mandatory ventilation. Okay, and there are other variables called controlled variables. There are two types of control. Is either pressure control, so the clinician control the pressure, okay, and the volume will be the interaction between the baby and the machine. That's called pressure control to prevent pressure trauma. And there are volume control, okay, volume control. And the volume control is more worse on the baby. The side effect of the volume is more worse than the pressure, because the pressure is the speed of time, is how fast you give the flow, while the volume is the time of the flow, so how long you give. And because it's the time and long, it causes more trauma. That's why it's only used temporarily, volume control. It's only used during surgery on healthy line by anesthesia. Okay? But now we are using what we call it pressure control. Pressure control, volume limited. So we use both pressure controlled, volume limited. There are mixed mode. So these are called controlled variables to give us not the type of ventilation, while the modes are dependent on independent variable, dependent variable, and phase variable, and the type of breath. Okay? Is it clear or difficult to understand? Do you hear me? Anybody hear me? Guys? Hello? Nobody? Are you actually listening? Are you actually leaving your mobile, or you're there? So let's start with Khalid. Are you there? No, don't text me. Just speak to me. I don't look to the text. Khalid. Khalid Hamid. Khalid Hamid. Okay, so it seems that Khalid is not here.
Assalamu alaikum.
Alaikum salam. Why you are not answering me, sir? Okay, so Khalid, you are there, okay?
Yes.
Actually, in the
Yes,
courses,
I'm
we should put the camera on. The only reason I'm not asking the camera on is because some ladies, and maybe they're shy or something, but in actual official course, the camera should be on. Let's say Payam, are you there? Payam Idris.
Yeah, I'm here.
Okay, Sundus Ali.
Yeah.
Sundus?
I'm here.
And
Yeah,
Iman.
I'm here.
Thank you. Iman.
Yes, yes.
Mustafa. Mustafa Hatem.
Yes, sir, I was there.
Mariam Uthman.
Yeah, Doctor, I'm here also.
Sumaya. Sumaya. Sumaya Juma. Okay, Sumaya is not here. Sarah Shakir.
Yeah, I'm here.
And Razana or Razhana Asad.
Awajna, we all here, but we don't speak.
Why? What's the reason why you don't speak? Because you have problem with language, or you use sign language, or why you don't speak? So what's the reason of not speaking?
We don't have question. We have question,
Yeah, but yeah, please ask question. The only way I learn, because I don't know your level, okay? The only question that and we are doing it online, so you are not with me. The only way I know who you are when you ask questions. So the question will help me to understand what's your need, and what's your level, because I might give more than your level or even lower than your level. I don't know anything about you. So the more you ask me, the more I know you, and the better will be the presentation. The more informative, more helpful is the information. But if you keep quiet, I don't know what to do. And we have Kausar Khalil. Kausar Khalil.
Yeah,
Okay,
I am here.
Sumaya.
Yeah, I am
Thank
here.
you.
Yes.
Sumaya Jum'a. And we have Rania Franci. Okay. So let me ask you, who's for you are good in peripheral line insertion? Which one of you do you think that you're good? So let's start with Khalid. Khalid, are you good with the peripheral IV insertion? Khalid,
Yes, doctor.
are you good with peripheral IV insertion?
Yes.
Okay. And you know, when I worked in Canada, the nurses are very strong. They are very talkative and they are very opinionized. And they're really good. They're very strict. So, okay.
But in child,
So
very difficult.
that is the nurses that I'm used to work. They're so difficult for patient care, of course, but on human level, they're very nice. Okay, Payam, Idris, are you good in IV or you think you need training?
For adult, I'm good. No need to training, but for child, I'm not good.
For the
enough.
child or newborn, which one you have difficulty?
Both. For both.
Both. Okay. Sundus
Child
Ali?
easier.
Yeah, okay. Sundus Ali? Do you have Venn viewer here or no?
Yes دكتور بس يعني
Are you good
repeat
in
your
IV?
question. Good, but in premature baby I'm not good really. But يعني
Okay. And
in our
okay.
RCU we say umbilical cannulation. We try it.
Okay. Do you use Venn viewer or no? Do
No,
you
we don't have.
do you have
I work in a ward
let me-
in a private hospital, but we don't have Van viewer. Just
okay.
in
So
pediatric
I
ward.
will show you some Venn viewer for newborn babies. I don't know if you have seen it before or not. So let me share my screen. I will show it to you.
Yes,
Okay.
doctor, using in the surgical room.
I will show it to you. I'll show you one. Do you see my screen now?
No?
Oh, okay, 1 minute. Do you see it now?
Yeah, you can
Yes.
see.
Do you see the hand of the baby?
Sure. Yes.
Do you see how it's easy to see the veins with the we site? This is called we site. This one, we site vein viewer. It's very cheap. It's like $100. So I always have it in my pocket. This one. So I use it to intubate, to cannulate the babies. You see it? We site is called. It's $100. And if you don't have, you bring a torch and then you put it in a glove and just switch it on, put it below the baby, turn the light off, and then you will see all the veins. And you will see the artery pulsating also. Easy to see. Okay? So if you are not good, you just bring a torch, put it inside the gloves, switch it on, put it below the baby. And the reason putting it in the gloves, not only for sterility, but because it's a torch and it's a hot, it can burn the baby. But this is used, it is like a vein viewer. It's very cold, so it will never hurt the baby. Only I put it inside the gloves when I do a sterile procedure. Okay, so this is called we-site, but also we have the vein viewer. Like we have more expensive ones. You see it? This is vein viewer. You see how you see the veins? Look at the vein. You see this? Do you see my screen?
Yes.
Yes, we
You see
see.
this? This is,
Yes, we
you see
do.
this is the,
Yes.
you see how you see it easy to,
It's a
look at
good
here.
machine.
You see how? This is a little bit expensive, but the other one that I show you is not that expensive. You can see how, and then I use it when to put central lines. Okay? And you can see this lady is using it. And you can fix it on the hand of the patient, so you can use it easy. It's called vein viewer. So if you are not very good in inserting lines, we can bring the vein viewers. Okay, so let's go to Iman, Umar. Iman, do you have experience on doing IV in newborn babies?
Yes, I'm good. I'm working in
You're
NICU and pediatric course for
okay.
2 months.
Okay, what about Mustafa?
Dear doctor, actually, most of my experience it was with adult patient, peripheral and central lines, no problem. But with
Ah, I see.
pediatric, I prefer central line within peripheral line, but
Okay.
it not be the problem for
So
me. It's
what
easy.
type of central lines you are using to insert?
It's a civil line, 7 French, subclavicle.
But are you putting in jugular or are you
internal
putting in
jugular.
jugular?
It's subclavian and internal jugular for femoral also. We was
Yeah,
do it.
I hate this line. I don't like them.
The
Jugular and
femoral is bad. Yeah, the femoral is bad, but the jugular it has complication with the hemothorax. Sorry, but for internal jugular,
Not only no, not
for
only
pediatric,
pneumothorax.
we don't do it.
Not only pneumothorax. They cause air bubbles, and they can cause heart failure in a premature baby. Also, they are a very high risk of infection. So I rarely ever use them. I think I've used the jugular twice in my life. I never use it. I hate it. It usually results in the death of the baby. It's a premature baby. So I never used it. So I use peripherally inserted central
Dear
lines.
doctor, the pediatric cases was not too much. So
So if we fail,
cases,
we can ask the vascular surgeon to do a cut down. So that's not a problem. But usually I will teach you how to do PICC line, PICC, peripherally inserted central line. Okay, let's go to Mariam.
Yes, doctor. Also, I did that before, but few cases. I mean, it's
So
يعني
have you
change
ever
according to the
inserted a
baby.
line in a premature baby?
A line, not central line, peripheral line, but not for premature or newborn baby, just for pediatric patients. So I didn't work in pediatric wards, just in surgical and medical wards. Therefore, also I'm like other friends. I know put the cannula or peripheral lines just for adults, better than the pediatrics.
And what about Sumaya Juma? Sumaya. Sumaya. Is she actually here? She never answered me. Okay. Sarah Shakir, are you a doctor or a nurse?
Nurse. I'm a nurse.
Okay. So have you inserted a line like a
Till
peripheral or
now,
central?
not. لا, till
Okay.
now, no.
What about Rajna, right? Rajna, right? That's how you say your name?
Yes, Rajna.
Rajna, you're a doctor, right?
No, I'm a nurse.
Oh, you're a nurse. Okay. So have you inserted a line?
Okay, of course.
Oh,
Peripheral
so you
lines.
do peripheral. Oh, okay. Okay.
Mm-hmm.
What about, okay, good. What about Kausar?
Yes.
Kausar, is I'm saying your name correct?
Yes.
Okay. Have you inserted a peripheral line before?
Yes, but in adult.
In adult, I see. Okay. You never did one in pediatric.
Yes, yes, but not newborn.
Ah, okay. I think we already talked with Payam, right?
Yeah, you you asked.
Okay. Yeah. So what I observed here that you guys are not dealing with the line correctly, and that's one of the reasons why you have high infection rate. So there are a few things that you're doing it. So you always open the line to air. So you disconnect and then you connect the syringe to give medication, right? Or I'm wrong? That's what you do? You disconnect the line, you keep it open, and then you connect the cannula and inject. Is that what you do, or I'm wrong?
Could you please repeat again?
So what you do is you have a cannula, and then you have the set connect to the cannula. So what you do is you open your set from the cannula, leave it open, then you bring your syringe and connect it to the cannula and inject. Is that what you do?
Yes.
Yeah, that is wrong. Not allowed. That is not a medicine. You
Yeah,
should
of course,
never
doctor.
open a cannula. You should never open a cannula. Never allow the cannula to air. Once you open it to air, you're causing infection. So that's one of the things that I saw here is you open the cannula to air. It should never open to air. So both should be neither the set nor the cannula open to air. So that's one of the risk of infection. So what we should use, and then we'll bring it to the unit, called Q-site. I don't know if you heard about it, called IV stoppers. So we connect here and we connect here, and when you disconnect them, they are closed. Okay, and then when you lock them, they are open. So they never open to air. The other things is when you open and give medication, you are not using sterile gloves. Remember, when you open the cannula, it should be like a surgical field. So you have to have a sterile gloves below it. You have to have a sterile sterile gloves, and it's preferred to have mask before you give medication. So I've seen the work here, and also you use a big bottle to take normal saline, and that's another risk of infection. So normal saline should be in small pieces in sachet. So you take and you throw it. You just don't break it again. Once you break it more than one, that's a risk of infection. So these are the practice that I have seen. It's a risk of infection. Okay. So we'll have like a session, complete session about how to deal with peripheral and central line, inshallah. And if you guys don't have question, I'm going to stop the session here. And tomorrow, not tomorrow, after tomorrow, we will have monitoring of GIT. So we finish with respiratory, we'll monitor the GI, and then we'll have cardiovascular, and then we monitor the CNS. Once we finish this all, we will move to other topics, which is ventilation. Once we finish ventilation, we will do the milk, type of milk, and feeding protocol. And because also I've seen that people here don't know what is milk and how they use the milk, because everybody think that the company write milk type 1 and milk type 2 for first 6 months, and that's all wrong. That is incorrect. And this is for whatever written by the companies that is completely wrong. That's not the way we give the milk. So we'll teach you how to give the milk and the type of milk and how these milks are called. And most of the company, they don't write the name of that to confuse the people and to sell more, to confuse parents and to confuse the staff. So nobody knows what is in. Okay? And so that's another problem that I'm facing here. Also, the pacifier and the TET also are confusing here. So we'll take the type of the pacifier and type of TET that we use for feeding. We'll talk about it later, inshallah. If no question, I'm going to close the session and we'll see you day after tomorrow. Any question or I should go?
There is no
Doctor?
question.
Thank you, doctor.
Thank you,
Afwan, Doctor,
Sanders.
bس
Thank you very much.
one question. If we
Please.
have a fluid on the patient, we are يعني busy, forget air go to the central line. What we should do? يعني how much cc is go to the patient is يعني
Which
خطرة.
line? Which line?
يعني central line or peripheral line.
Okay, there is principles. There is principles. I will tell you. No line should be free to air. One. When you open the line, when you disconnect, it should be surgical field. Third, there should be no line without fluid. There should be no cannula without fluid. You cannot keep the cannula without fluid. You have to run at least 0.5 ml per hour. Each cannula should never leave left without line infusing, because that will be clot, that will be needles for infection. So no line without infusion, whether peripheral or central. So that's a principle to prevent infection. If you leave, say you disconnect, you put medication and you close, and then you flush, I know that's what you do, you flush. That's a flush, a big problem here. It causes infection. So first, these are the principles. You should never leave the line without infusion. I don't know if that's your question. Now, if you're doing arterial line, you should give at least 1 ml per hour through the line. Now, most of the time we give half normal saline, but sometimes we give normal saline, and sometimes we give D5. Very rarely we give D5. But without infusion, the blood will come back to you. Okay. Now, each infusion syringe have a pressure, whether it's infusion pump or infusion syringe, they have a pressure. And this pressure either measured by quarters, so they have 4 quarters, and you need to document that every day. We will talk about when we take the cardiovascular. So you need to document that every day. And if today is only 1 quarter and tomorrow 2 quarters, that means the lines start to clot. So you have a problem. It's a risk of infection. So that's why when I come in the morning, I always need to hear the pressure in last 24 in your line. And that's why I know whether your line will be expired or not, and you have a risk of infection or not. Now, most of the time in the arterial line, we don't give medication unless it's life-saving. So we don't have access, we have an arterial line, we can give medication to save the life. For the UVC, minimal, if UVC is less than 1 ml an hour, it has to be removed. So we don't give UVC without at least 1 ml per hour. If it's less than 1 ml hour, then probably we don't need it, we have to remove it. And if it's more than 11 days, we have to remove it. When the day of the line is 11, we have to remove it. Some people keep it to day 28. And now this depends on the risk of benefit. If you don't have an excess baby edematous, we cannot put line, and he's sick, then probably we should keep it. But if we have other alternatives, we should. For the PICC line or peripherally inserted central line, we use it for like 21 days, mostly. Rarely I go to 28 days. PICC line should be minimum 1 ml per hour. If it's less than 1 ml per hour, and that's usually happen when we are having the line only for antibiotics. Okay, because we don't want to insert antibiotics line, because usually the peripheral take 3 to 4 days. So we need to run at least 1 ml an hour. Usually when we have long course of antibiotics, such as we have osteomyelitis or, let's say meningitis, okay, or you have a gram-negative sepsis, then we need long-time antibiotics. It's usually, and that's usually, most of the babies who's on antibiotics, only 1 ml, they are on full feed, so probably won't have a problem. And then we need to monitor the pressure. Now, for jugular line and femoral line, I don't use them. Rarely ever I use them. And if they are inserting them in the surgery, I usually remove them because they are a huge risk of infection. Did I answer your question, or you answered, your question was a different?
Doctor, my question about if we give the patient 1 cc of air, and how much is terrifying the safety of the patient?
None. None. It goes to the lung and it will go out in the lung. That won't be a problem.
What we should do,
once
doctor,
you give
if
it to the
air go through the
you don't
line,
do
what we
anything.
should do?
You don't do anything. If there is air, you go to the baby, you just wait, it will go out. It won't be a big problem. Unless it's a big amount,
Okay.
because the air is compressible. You know, the heart contract and there is blood, and the blood is non-compressible, so the heart can push the blood. Now, if you have actually, I use the air to test sometimes the baby. So I test where is the line. Before we used to give air, so we see, and then we put an echo or ultrasound on the baby, and then we give air and see the bubbling. So air is not a big problem if it's less than 20 ml per kg. If it's less than 20 ml,
Doctor,
and a healthy baby.
I think she
Sorry?
means
Yeah, somebody injects air in the
I
line,
think
right? Or is that
I
the
think
question,
she
Sundus?
means
Yes, right, doctor. If somebody inject the air in the line, what we should do? What is and how much is safety? You said 20 mil is safe
20 ml
per kg.
20 ml per. It's not safe, but probably nothing will happen if the lung is healthy,
Okay,
because the
just
you
my
know in
question.
the line, if it's a venous line, from the line it go to the inferior vena cava. From the vena cava, it will go to the right side, and from right side it will go to the pulmonary, and from pulmonary
Right.
it will go to the alveoli and go out.
Tamam.
Okay.
Thank you,
Now,
doctor. Thank you.
yeah. So usually, if it's very risky in sick baby, so it might be way less and causing a problem. But air
it
bubble
doesn't
should never
cause.
Okay.
occur.
Sorry,
If
it
you are
doesn't cause.
using
Okay.
AV, go ahead.
Sorry for interrupting you. It doesn't cause pulmonary embolism or something like that, or it's different.
Pulmonary embolism is a different topic. It was a problem
Okay.
if you are very sick, okay, because air is compressible, right? Blood is not compressible. So heart contract, push blood, right? While if there is air in the heart, okay, if there is air in the heart contract, the air compressed, and then heart relax, the air will expand. So compress, expand, so the heart end up not working, not pushing blood. That's the risk here. And
Okay.
and
Thank you,
if there is direct connection between right and left, there is ASD, for example, or VSD, is very risky because it can go to the brain. Because from the pulmonary, from the inferior vena cava and superior vena cava, it goes to the right atria, and from right atria to go to the right ventricle. And if there is ASD or VSD, it goes to the left. So the body push it to the brain, and because it's air and compressible, it's preferentially goes to the brachiocephalic, and from brachiocephalic goes to the brain. So this is another risk. Okay, so first risk is compressible if it's a big amount, and second risk, it can escape to the left side, and it's very risky if it's, that's why it's very risky if it's on the arterial side. Okay, if it's in the arterial side. But the good news in the arterial side, it's the heart push blood toward the artery, and usually it goes back and evacuate. So if it's in the artery, you should disconnect and remove it. If it's in the vein, these are two risks. If it's a huge amount, it's cause non-functioning heart, and if there is ASD or VSD or PDA, then there is risk that they want to go to the left, and from the left goes to the heart, to the brain, and cause air embolism.
Okay.
Clear?
Thank you, doctor. Clear.
Yeah.
Thank you.
Any question? Actually, I have seen it before. I've seen air embolism in the brain. I've seen it before. Although some of the brain, it goes like it goes like air below, and that's normal. So don't affect the baby, but sometimes babies are affected. Yeah, you need a really big amount to affect the baby. I think it's 20 mil, but I might be wrong, might be less, might be more. I'm not 100% sure, but I think it's around 20 mil. But I don't have the number in my mind. I might be wrong. But these are the risks when there is connection between right and left, and also when it's a big amount and it's not relieved and stay in the heart, it causes the heart non-functioning contraction. Okay, no questions? I will leave. I gave you a copy of the ventilation monitor, and next session will be, inshallah, GIT monitoring. and a little bit more difficult than ventilation because lots of topics, lots of terms that you are not used to. But I hope that you will learn. So I'm hoping that you're practicing how to present a baby the first session, and you start practice how you monitor the ventilation, inshallah. So probably within 1 week we'll meet and do hand-on, inshallah. So if no question, I will end the session. Okay? Good night.
Okay.
Bye-bye. Have a sweet dream. Okay? Enjoy your night. Bye-bye.
Thank you.
Bye bye.